Thank you, Dr. Amana, for the kind introduction. I will start my presentation on rhabdomyolysis. These are the outlines of my presentation. I will start with the case, just to pick your brain and to find what's atypical about the case. Then definition, pathophysiology, etiology, investigations, and management. I will try to keep on time. I have to compete with the previous speaker to finish really before the time finishes. So we start with the case. Your task is to find out what's atypical about this case presentation in a patient with rhabdomyolysis. So this is a 26-year-old woman living with HIV, known to drink alcohol excessively, was brought to the emergency department comatose. She was found laying in bed for more than 24 hours. The labs are as shown. I first wanted to highlight what's abnormal in the labs, but since it's like a total chaos in the labs, you can see that all of the labs are abnormal. So the sodium was 134, potassium 3, chloride 100, bicarb low 16, creatinine and urea are high. And for the sake of the discussion, we'll assume that this is a new finding. Calcium was low, phosphate is low, urate is high, albumin is low. And the urine analysis shows red-brown urine with blood that is positive in dipstick and the microscopy was negative. Some proteinuria, the sediment showed brown casts, and the FeNA was less than 1%. The toxicology screen was positive for cocaine and dimorphin. So can anyone shout out what was atypical in the presentation? I heard low potassium, yeah. So low potassium, low phosphate. So we'll get to know more about rhabdo, but in this case, the low potassium and low phosphate were actually triggers for the rhabdomyolysis in a patient with cocaine overuse. So what's the definition of rhabdomyolysis? It's a state of muscle injury that results in the leakage of muscle intracellular components into the bloodstream and can lead to several forms of systemic insults. Around 10% of all patients with acute kidney injury have rhabdomyolysis, and patients with rhabdomyolysis present with acute kidney injury in 50% of the cases. And this is only an estimate because there are many patients who have subclinical or who are not diagnosed because they did not have any symptoms. I'll start with this slide shows the pathophysiology. So regardless of the cause of the rhabdomyolysis, whether it's a direct insult to the cell membrane, a crush injury, or via ATP depletion, the net result is a sodium influx into the cells. As you can imagine, the sodium-potassium ATPase, which needs energy, is not working. So there will be an increase in the intracellular sodium. Then the sodium-calcium exchanger will increase the intracellular calcium, thus leading to further damage into the cell membrane and the mitochondria. So the net result is mitochondrial damage, apoptosis, and muscle destruction. So that was what happens at the cellular level, at the muscle level. Now, what happens systematically is that the contents of the muscles will spill into the bloodstream, leading to capillary damage. The myoglobin causes direct myoglobin cytotoxicity in the tubular cells. So this is just to summarize what I just said. So there will be tubular toxicity, which can be because of the iron-free radicals or the iron that is actually bound to the myoglobin that can cause the lipid peroxidation and further tubular damage. Vasoconstriction, since there will be capillary leakage and intracellular volume depletion, RAS activation, leading to renal vascular constriction. Now, like, why did I put a question mark here with the tubular obstruction? We know that the binding of myoglobin to the TAM-Horsfield protein into the tubule can lead to pigment casts. But are they really causative of the insults or an innocent bystander? Some animal models have shown that the intratubular pressure is not really high. That's why I put the question mark. So then we know that the triad of muscular pain, muscle weakness, and reddish-brown urine, but the patients who present with the triad, the three things together, are around 10% of all patients. So some patients will only have muscle pain or only reddish brownish urine, or some will be totally asymptomatic. Etiology, we can think of a person who works under extremes of temperature with inability to sweat, like, for example, firefighters or footballers. Like to put it together, I'm concentrating on patients with exertional rhabdo here, that patients who exert themselves and who are not dehydrated, who work a workout that they're not used to doing usually, those with sickle cell traits or medications, and eccentric loading. I added another table for the etiology as acquired and inherited. So the acquired, I highlighted some of the causes earlier, but I would like to highlight some more causes. Like in our case, the patient was HIV infected, so infections, viral infections can also be the cause. Then endocrinopathies and toxins as well. I will highlight when to think of inherited disorders in a while. So investigations. Some of the investigations that we may request initially are non-specific. So like if you look at the CBC, there might or might not be heme concentration. Inflammatory markers may or may not be high. I'd like to share a story actually from my early residency days. There was a patient who was admitted with rhabdomyolysis, and AST and ALT were very high. And I thought I will be proactive, I'll call gastroenterology. So I called gastroenterology for the patient with rhabdo with high AST and ALT. And I'm like, doctor, I'm wondering why this patient has high liver enzymes. And he's like, you are wondering or your consultant is wondering. Have you ever heard of isoenzymes? I'm like, okay, sorry. So yeah, just the take-home message is that the AST and ALT can be elevated, which are muscular isoenzymes, not really from the liver. The reason why I put this slide is that just to think about the timeline of the elevation of multiple blood tests. So like the myoglobin is the first to rise, but it's the first to decrease as well. CK is the so CK elevation, like what's the level that you would think of, oh, does this patient have rhabdo or not? There is no magical cutoff value. Some would say like 5 times the upper limit, or more than 5,000, or more than 10,000, but the literature is not really consistent on that aspect. It's important to follow the creatinine kinase, and it's important to that by the 3rd to 5th day, the creatinine kinase is supposed to decrease. If it doesn't, then look for an ongoing insult in a form of compartment syndrome or an agent that has not been stopped. And then like creatinine as well is can raise not on initial presentation. This is a score that can tell you the susceptibility of the patient to get acute kidney injury or need of renal replacement therapy. You can find it online. The variables that are used are the age, gender, initial labs including creatinine, calcium, CPK level, phosphate bicarb, and one of the other variables is the etiology of rhabdo. I don't advocate doing a kidney biopsy, but if a kidney biopsy is done, what we can see is on immune histochemistry is myoglobin positive casts. When to screen for a genetic disorder, you can use this mnemonic, rhabdo. So recurrent episodes of exertional rhabdo, high CK that is persistent. The episode was triggered by not really non-accustomed physical exercise, and if the CK is really high, more than 50, the upper normal limit, if the drug is not to blame, if the patient has other family members who have history of rhabdo. The complications, as I mentioned some of them already, and you might already know, the acute kidney injury, and we treat it with IV fluids, bicarb, I will touch on that, and hemodialysis. Compartment syndrome, the treatment can be fasciotomy if the patient has compartment syndrome. hypovolemia, hypocalcemia initially, that may later become hypercalcemia. So be careful of replacing calcium in these patients, especially in those with hyperphosphatemia, as well as that may trigger precipitation of calcium phosphate crystals into the muscles. Hyperkalemia, which is may be life-threatening, and late complications include DIC. So guidelines advocate for the use of crystalloids and aggressive hydration, more than 10 liters in the first day. And if ringer lactate can be used, but avoid in early, at an early stage, as it contains potassium, and especially you have to follow the potassium level on those patients using in whom you use ringer lactate. Alkalization of urine, while animal models show that it can be helpful in terms of decreasing like the tubular toxicity. The systematic reviews have not shown a great benefit, but maybe because there was a bias in the studies that used alkalization of urine has also used mannitol in the treatment. Renal replacement therapy, it can be used in patients with refractory fluid overload, hyperkalemia, acidosis. There's no role of using the early renal replacement therapy to decrease the myoglobin level. There are some case studies and case series on the use of adsorption and high cutoff membranes. They have shown to decrease the level of the myoglobin and the CK, but not really affect the clinical outcomes. There is one study that looked at paracetamol use, and they concluded that it actually reduces the risk of renal replacement therapy. Most of the guidelines would say avoid mannitol, as it can cause further osmotic nephrosis, and it can cause further electrolyte imbalance. Avoid calcium replacement, as I just mentioned that although calcium can be low initially, there will be a rebound hypercalcemia. I would like to highlight this on this slide, that sometimes the changing of legislations can lead to a reduction in some diseases. When I first started residency, there will be like a rush of patients with rhabdomyolysis during the hot summer, during the peak of heat in summer, and which anecdotally I can say the number of patients have decreased. I haven't come across any of studies looking really at the incidence of rhabdomyolysis. Thank you very much.